Right, so this audio lecture is going to focus on allergies and different types of allergies, how they arise from an immunological perspective, and also treatments. And then at the end, there are some slides in your PowerPoint that are about alpha-gal. There's already a separately recorded audio lecture for those. So when we look at allergies, they can arise from several different forms. So allergens can be presented either from inhaled material, injected material, ingested materials, or contact. Okay, and so if we think about inhaled materials, those are going to enter through the respiratory tract. So those could be like mold spores or pollen. So things that we think of like seasonal allergies or environmental allergies. But keep in mind that sometimes allergens that normally come in one route could enter through other routes, such as inhaled, and I'll talk about that in just a moment. Injected materials. So this is where we have drugs that, prescribed drugs, monoclonal antibodies that are used, and individuals can either develop or have an allergic reaction to them. And because they're injected into the bloodstream, that's going to present differently than if it was a respiratory allergen. Okay. Also, when we look at things like insect bites such as insects with venom, those we can develop allergic reactions to the venom. And again, that's going to go directly into the bloodstream. And then we can have ingested materials. So commonly we think about these with food allergies, but this could also be drugs that are like orally administered. Now with food allergies, again, just to point out that we could have an allergen that normally we ingest and then have allergic reaction to it. For some food allergies, even if the material is in the air, individuals can have a reaction, but those symptoms might present differently because it's through the inhaled method, right? So instead of the digestive system being the primary site where the allergen is present, we would have it in the respiratory system. So again, the individual might present with different sets of symptoms because, as you'll see, the response is going to be different by different tissues. And then lastly, contact material. So, classic example, poison ivy. You get the oils from the plant on your skin. And then you develop a skin reaction to it. We can also see metal allergies. So if you've had like a body piercing and you didn't know you were allergic to nickel, obviously then you could have a reaction and that would present differently. So we can have, and again, so keep in mind with each of these different allergens, depending upon how they present, it would affect different organ systems as their primary. But once that material gets absorbed in, we could then have a systemic reaction where we present with something like anaphylactic reaction. So we're going to primarily be talking about allergies, which is a type 1 response. So you can see here on this figure, this is where we have the antigen or allergen present, and it's going to bind to IgEs. Those IgEs are bound to Fc receptors on mast cells. They can also bind on basophils also. But the primary response for type 1 is coming from the mast cells and the IgEs binding to them and then binding to their allergen. When that happens, that signals cell signaling events, which causes mast cells to degranulate. So what you're seeing here in the bottom panel is that degranulation, so everything in those granules is being released. Histamine is the one we focus on, but you'll see in the later slides that it's not just histamine. There's large amounts of other immune mediators that will cause inflammation and a response, recruit in additional immune cells to try to clear out that antigen. Keep in mind, this is meant to be a protective response because this is foreign material that our body didn't recognize as us, and so we want to respond to it. It's just that from a day-to-day perspective, these allergens really aren't that dangerous, and we'll talk about why the reaction may be happening in a little bit. But When we're talking about the allergen for type 1, again, these are those allergens we were just talking about. Things like pollen, right? We are exposed to that every single day. Food, we're exposed to that every single day. So it's actually not beneficial that we respond to it. But again, this is actually rooted in a beneficial response that we'll talk about later. Again, primarily you're responsible for knowing the type 1 response, but you should know the other 3 responses. So type 2 response, this is, an example of this is where we have a protein that's present or an antigen that's present that's not normally present. So a classic kind of example of that is a blood transfusion. So you don't express the surface markers on those blood cells that you have been given, and because it's a mismatch, then you respond to it. So with the, type 2 responses, IgGs or IgMs are going to be the primary responder. So they're going to bind to the antigen, and then that is going to cause activation of macrophages, which then leads to a response. The other example is with penicillin. As you can see here, penicillin is going to bind, and it's binding to surface proteins, and that causes it to look like a new epitope. So the B cell responds to it, produces, secretes antibodies against it. So it's really the second time you're being exposed to penicillin, and then you end up developing a reaction to it, a hypersensitivity. Type 3 response, this is where we have complexing of antibodies against a foreign protein. And so an immune complex is going to form. Okay, so this would be more with like a soluble antigen versus with type 2, an attached antigen. So in this case, sometimes what you'll get is like complement and inflammation and phagocytosis occurring in these type 3 hypersensitivities. So the example here is with monoclonal antibody therapy with mice. So that's not normally in you. You don't normally have most antibodies in you. And so the B cell recognizes that as foreign, binds to it, secretes antibodies, and then these complexes are able to form between those monoclonal antibodies and your antibodies, and the immune system sees that and responds, but in an over response, right? So you get complement, you get inflammation, phagocytosis occurring. The last hypersensitivity, type 4, this is driven by lymphocytes, so usually T cells, so CD4, CD8 positive T cells recognizing antigen and then eliciting a further response. This is also referred to as delayed type hypersensitivity because it takes a while for the T cells to respond, and so usually for the T cells to respond and then help B cells to then produce antibodies. So usually when you're exposed to the allergen, it's not an immediate response. So type 1's usually immediate. Type 4 is usually a delay, and usually it's like 7 days. You see this sometimes with penicillin allergies. So there's the penicillin allergy that's a type 2, that's a little bit more immediate. With type 4, this would be days later after having it. So you get the body piercing, you think you're all fine, you're not allergic to it, and then you wake up, a couple days later, and you're like, oh God, it's all like swollen and infected looking, and it could be infected. It might not have been a clean piercing, but if it was a clean piercing, then that would be an indication that maybe you have a nickel allergy or an allergy to the metal that is in that piercing. Okay, so you can see here how these T cells have now recruited in macrophages and other immune cells to then try to fight to clear the allergen, or not the allergen, the metal, the nickel. So this just outlines everything I just said. I also really like this figure from a different textbook. I like that it summarizes the immune mediators, so you don't have to kind of pull that out from the figure that's in our textbook. So again, you should keep in mind that if you're seeing an IgE that would be an allergy type 1 response. If you're seeing IgG or IgM, that's a type 2 response. And then with type 3, this is where we have immune complexes forming. So it'd be some kind of like, antibodies binding with antigen, but more in a soluble type form. And then lastly, type 4 or delayed response, that's where we're going to have T cells involved in that. So do keep in mind that with in that bottom row, you can see that there's some classic examples of these different responses. So again, type 1, we would think of allergic reactions, whether it's anaphylactic, whether it's hives, whether it's food mediated, whether it's environmental mediated. For type 2, classic example is blood transfusions. So if it's a mismatch, that response that happens. Classic example for type 3, some autoimmune disorders are actually type 3. So things like rheumatoid arthritis, lupus, those tend to be a type 3. And then for type 4, this would be something like contact dermatitis. And then we also see with type 1 diabetes, that is a type 4 reaction. All right, so thinking back to these reactions, especially type 1 with allergies, where the heck did this arise from? And so when we look at these hypersensitivity, it's really this arming of the Th2 response. And so if you remember from our last unit, Th2 response is where we're responding to parasitic worms or hemolysis, okay? And if we look at the cytokines that are being produced and the antibodies that are being produced and the effector cells, it really speaks to this normally is a response to parasitic worms, but something's gone awry. So instead of the immune system recognizing that, oh, there is not a parasitic worm here, we don't actually have to respond to this pollen, and they keep going. Like maybe there is a parasitic worm there and we just can't see it. And so if you had a parasitic worm infection, we would see activation of xenophils, basophils, and mast cells. And again, that's what we see in especially a type 1 response, but with these hypersensitivities. So there are a number of theories to try to understand why individuals have allergies and some individuals don't. One of those theories is the hygiene hypothesis. So with the hygiene hypothesis, where this kind of arises from is they looked at the distribution of parasitic diseases, parasitic worm infections. And you can see in the red, those are where countries where there's pretty common to have parasitic worm diseases and to have parasites, you're living with parasites in your gut. And, you'll notice that the U.S. is not in that red. And so in the U.S., we tend to have very low incidences of parasitic worm infections, especially to the ones that they are clinically presenting. It's not that it doesn't happen. There's definitely individuals, like farmers who are living, not living with livestock, but are constantly caring for livestock and getting exposed to parasitic worms. They would have cases of it. And generally, for a healthy individual, we're able to keep the parasitic worms at a nice level because we have things like eosinophils and mast cells and basophils that are able to keep a balance between those. Okay, so keep in mind that our kind of vision of, if we have a parasitic worm, we're going to be malnourished and we're going to be unhealthy is a little bit skewed, right? So on top of that, and understanding that our microbes that were present generations ago are not the same microbes that are present nowadays. So there's been a huge shift in our microbiome in the US and developed countries. Also, when we look at vaccination, though there's great benefits of vaccination as far as outcomes, there is potential that there is changing of how our immune system is responding versus with a natural infection, okay? Vaccines very much mimic this, but they're not exactly the same, right? So seeing just a little portion, like one protein from a pathogen and getting an immune response isn't the same as seeing the thousands of proteins that are on a pathogen. And we also, if we look at these developed countries, there's also a high reliance on antibiotics. Again, similar to vaccines, similar to, being clean and washing your hands and, sanitizing certain areas. Antibiotics have a purpose, right? So we know that a large number of individuals would actually die from bacterial, viral, and etc. infections if we didn't have antibiotics and antivirals. So they have a role in our society, but there's a difference between using them wisely and then just prescribing them because that's the easy thing and it keeps the patient happy. So with the overuse of antibiotics, we're seeing more super bacteria, and those are the ones that are interacting with our immune system. So when we put this whole picture together, this really puts our immune system on a different playing field than it was generations ago. And so its ability, the training that happens. So if you think back to Unit 1 in our journal club paper, what your immune system is developing from day one is going to dramatically change if all these factors are at play, right? And there's guidelines we can put in place for antibiotics. And again, vaccines have a use because we don't want people dying from preventable diseases. So the big one is really about exposure to microorganisms. And so thinking about when we're excessively sanitizing, sterilizing everything, all the surfaces we're interacting with, what does that have? What effect does it have? When we're not going outside and playing, and again, when we're going to the grocery store and getting all our food and we're not actually raising our food ourselves and gardening and raising livestock. And obviously that's not feasible for everybody. But again, we need to be aware of how does this change our immune response and what can we do to kind of correct that. So that's kind of the hygiene hypothesis in a nutshell. And there's a lot of other reasons that we could be seeing allergies. And again, we'll talk a little bit about those in a little bit. All right, and so for major driver for allergic reactions are mast cells. So if we look at mast cells, and you'll see that there's the mast cell on the top for an anti-parasitic response, and then we have our mast cell for allergic response, you'll notice that they have multiple FC receptors, and the FC receptors are binding to different IgEs. The different IgEs are going to be able to interact with different molecules, different allergens, different proteins, molecules that are found on different parasitic worms. So again, think back when parasitic worms were kind of the norm, or in a country where parasitic worms are the norm, the mast cells would be interacting with different parasitic worms, and that's what their FC receptors would be binding, is IgEs that recognize those, right? Well, when we're in a germophobic society, in a very sterilized society, and we're not getting those interactions with parasitic worms, the mast cells end up binding IgEs that actually recognize allergens like pollen, like cat dander, like peanuts, like bee venom, right? And so the mast cell starts to have a different function in the immune response. So what's been done to block the binding of IgEs that would lead to an allergic response, degranulation of the mast cells, is designing a human monoclonal antibody that will bind it. So omalizumab, or Xolair, which is the name brand, is a monoclonal antibody that's been developed. It's been tested for asthma, but is used in other cases of allergy where you have idiopathic hives that don't resolve. And so in taking that monoclonal antibody, as you can see, it's going to bind to the IgEs. So the IgEs can't bind to the FC receptors, which means mast cells don't degranulate, which means you don't get the allergic reactions because all of those, histamine and immune mediators aren't being released. So when this therapy was first proposed, it was met with a lot of discourse. And part of that reason was because anti-IgE antibodies were actually looked at in the lab to activate mast cells. So what they would do was they would take IgEs, the IgEs maybe were from individuals, and they would be able to bind the Fc receptors. So you get that initial, what you're seeing on the right panel. And then they would add anti-IgEs that would bind to the binding sites, and that would activate the mast cells. And so again, that's how that was done in lab. Similar assays were done with basophils. And so you can imagine scientists, researchers, clinicians were like, whoa, 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 this is how we activate mast cells, is actually adding anti-IgEs. So it was really important to make sure that the IgE that they're using for the monoclonal antibody therapy like Xylor actually wasn't binding to the binding site, but binding to the Fc receptor, right? So where you bind on the antibody makes a difference whether the antibody is going to activate, thinking it bound to its allergen, which you're seeing on the right panel, or whether it blocks the binding of it. So as I mentioned, and I've mentioned throughout the semester, mast cells release histamine, but they release so much more than that. So there are estimated to be about 200 different proteins, molecules that a mast cell will release when it's degranulating. So I have picked on one. As you can see, there are different enzymes. So enzymes are going to be important for breaking down connective tissue that are present in the area where we have the allergen present. We also have cytokines present. Cytokines are going to be pro-inflammatory to activate other immune cells that can help in fighting this allergen that's present. You'll notice that some of these cytokines are going to promote xenophil production and activation. That becomes important because xenophils are also play a critical role in parasitic worm infections, but then also we see in developed countries like the US an increase in the xenophilic diseases. And we'll look at what xenophils release in just a moment too. There are chemokines that are produced, and there's also lipid mediators. So you'll notice that the lipid mediators are going to act on smooth muscle, and that is going to change the contraction of those. It also can increase vascular permeability, also increase mucus secretion. So again, think about when you've had an allergic reaction, what were some of the symptoms that you had of it? And again, whether that was a seasonal reaction or whether you have like a food allergy reaction. So I mentioned you're going to get the mast cells actually activating xenophils. And so from that, xenophils are also going to be releasing different enzymes, toxins, chemokines, cytokines, and lipid mediators to further, cause inflammation and immune response. So keep in mind, xenophils are a specialized granulocyte, and so they are critical for when we have a parasitic worm infection. The image you see here is what a xenophil looks like underneath the microscope. So you can see those granules. So just like mast cells, they have these granules that have these immune inflammation mediators present. So when we're first exposed to our allergen, keep in mind that we don't have the B cells activated, so we need to do that, right? So first time you're exposed to pollen, you may not have any response to it. So when you move to an area, the first season might be great because, again, you haven't been exposed to that pollen of that region. But what happens, that gets into your airway, you then have antigen presenting cells that are going to take up that antigen because, again, pollen, though it's benign, it is foreign. So your immune system is doing the correct thing, and that is going to cause the antigen presenting cell to process it and then present it to T cells, specifically to follicular T cells. Those follicular T cells then will interact with B cells. Those B cells become activated, they will secrete antibodies. So, and those antibodies have undergone class switching for IgEs. So again, something's telling these B cells, oh, there is a parasitic worm infection, even though it's just an allergen that's present. Part of that is due to the IL-4 that's being produced by that T follicular cell. Now you have our B cell that's producing IgEs, and so those IgEs can then bind to the Fc receptors on mast cells, and now it's just a waiting game until we see that pollen, that allergen again. Okay, so again, this is the first step that has to happen. And this doesn't happen in everybody. So not everyone will develop allergies over their lifetime, and also allergies will change over your lifetime. So there's a number of theories. So we talked about hygiene hypothesis, but it's also believed environmental factors or genetic factors can also play a role in who develops allergies or not. Now, when we have allergens, usually what happens is we get a biphasal reaction. So there's usually an immediate response and then a later response. So if we're talking about something like an inhaled allergen, which we're seeing in this panel, we can actually have changes in the filter rate. And so you can see there's an immediate drop in that filtration rate, but then it kind of recovers. But then if we look hours out, we see a second response and drop. Now, this individual here has a contact reaction where they have a hive developing. So you can see immediately there's a hive spot on their forearm, but then later this becomes a general swelling edema event that's happening. So, and we see this with GI presentation. So you'll get a immediate kind of response, nausea. It might, if it's severe, you might even have vomiting, but then there's usually a later phase that's hours later. And the reason why we have these different systems involved is because there's mast cells present in these different systems. So depending upon where mast cells are degranulating, whether it's only one organ system or multiple organ systems, you're going to get different symptoms, different responses. You can see that with the GI tract, you're going to get increased fluid secretion and peristalsis. That means things are going to move through the GI system quicker, so that can result in diarrhea or even vomiting. For the airways, there will be a decrease in the diameter, so a shrinking of airflow. And then we also get increased mucus secretion. So again, if you've had seasonal allergies, you know that mucus production that happens. So things like coughing and sneezing and expelling of phlegm will happen. With blood vessels, if it's either in the bloodstream or if it's been absorbed through the skin and gets into the blood vessels, we can have increased blood flow, increased permeability. So we'll get things like edema, that's swelling and inflammation. And this can also lead to increase, the purpose of this is to increase the flow of antigens to the lymph in the lymph nodes. So an individual might also notice that there's swelling, in their lymph nodes get swollen because there's more material in there, and also you're activating additional immune cells. So you can see here with an allergen that's in the bloodstream, it's going to be able to enter different tissues and activate these mast cells throughout the body. And so again, so once it's in the bloodstream, it can have additional reach, if you will, to different organ systems. So as we've mentioned with the respiratory system, we can have contractions of the smooth muscles. So we get constriction of the throat and airways. It can become difficult to swallow or breathe. Wheezing happens. GI system, again, we can get effects on the smooth muscle because we have all histamine and all these other immune mediators being released. So things like stomach cramps, vomiting, and fluid outflow into the gut, and diarrhea. Now, if the heart and cardiovascular system is affected, this is where we get increased capillary permeability. So the fluid can enter into tissues. So we can get swelling, and swelling of the tongue can happen. We can get loss of blood pressure, so we can get severe drops in blood pressure. At the same time, you can get an irregular heartbeat, and you can get increases in blood pressure too. So there's drops in blood pressures, but some people actually have an increase in blood pressure because the heart rate will actually speed up with that. With a loss in blood pressure, you're going to get a reduction of oxygen to different tissues, including the brain, and so this can cause neurological presentation also. In severe cases, either due to the loss of blood pressure or loss of oxygen flow, this can lead to someone becoming unconscious too. Okay, so I have this figure down here on the bottom, which is from a article that you have the citation for that shows some of the different organ systems and presentation in a more patient-friendly way. Just keep in mind, anaphylactic is not just respiratory. Okay, so there's if there's one thing I can have you take home for this whole entire semester is that if someone is presenting to you, they may have anaphylactic and they can still breathe, right? So if you have severity of symptoms in the heart or the GI system, that can be anaphylactic. They can be having a severe systemic reaction that then in the second phase could lead to issues in other organ systems. So remember, allergic reactions tend to be biphasal. And if they are presenting in severe case and severe symptoms, and we'll look at what that means, in two organ systems, even if it's not breathing, they should use epi and they should go to the ER because the second phase might affect the respiratory tract and that might lead to not being able to breathe. And if the heart's involved, this is where some individuals, the strain on the heart will be so severe it can lead to cardiac arrest. So here, when we're talking about the blood pressure, again, this is what, if you were looking at a patient while they're undergoing anaphylactic reaction, you would notice that there's a drop in blood pressure. If the individual or others around them recognize this, they can administer an epinephrine, maybe through an EpiPen. There's also a new delivery system where it's an oral dissolve, and the uptake of the epinephrine is in par with uptake of epinephrine through an EpiPen. So that is going through approval. So excited. And so once epinephrine is delivered, you can see how there's a rescuing of the blood pressure for that. Now, epinephrine has its own complications. So if it is administered again, the individual should be going to the ER to be monitored because it puts a tremendous amount of stress on the heart. So individuals with compromised heart due to heart disease, genetic reasons, are usually not advised to administer use an EpiPen, but at the same time, it's a life-threatening case if you have systemic anaphylactic, and so it's kind of a risk analysis that has to be done. So for individuals with allergies, they should be aware of an emergency care. This goes, not just with food allergies, but other allergies. Just because you haven't had an anaphylactic reaction doesn't mean you can't have one in the future. And so the rule of thumb is that if you have two organ systems where you have symptoms, you should be administering epinephrine, okay? So this is a really nice handy kind of sheet, especially for someone who is new to allergies, to kind of do an assessment on whether they should use epinephrine. I know a lot of individuals go more for looking at severe symptoms and whether they should administer it, because if every single time you had mild symptoms and it was in two organ systems, you'd be using an EpiPen all the time. This is where it's really important to consult with your doctor, your PCP, your allergist, and also get their advice. But again, just be aware that anaphylactic reactions are not just respiratory. There are other organ systems. And if you look at these severe cases, severe symptoms here, if you have any of these severe cases of one organ system, you should be injecting epinephrine, or if you can use the oral, you should use the oral delivery of epinephrine. But again, it's really important that the patient goes to the hospital to be monitored because epinephrine can lead to high blood pressure and stress on the heart, and also allergic reactions are biphasal, and so patient delivers epinephrine, they think they're better, and then a couple hours later they rebound and they end up in a worse situation than they were before. And in that case, maybe if they only had one EpiPen on hand, they don't have a second EpiPen to deal with that second wave. So when we look at allergic reactions, there's a lot of variability in presentation of symptoms. And so the clinical symptoms really depends on how the allergen enters your body, right? So what mast cells end up getting degranulated? Does it go into your bloodstream so you have a systemic reaction? The concentration also matters. So there, as we've seen, too much sometimes can lead to a more of an allergic response where the cells aren't responding. Too low of an amount, there's not enough of it to elicit to get through the threshold to cause a response. Whether you have prior exposure to the allergen is important because, again, keep in mind the first time you're exposed to allergen, you haven't developed the B cells and the antibodies to it, so you may not respond. So someone can be like, well, I've had this before. Why am I reacting to it now? Well, because the first time you had it, you didn't have the B cells and the antibodies to it. Genetics also plays a role. So again, there is genetic factors that put you at a predisposition to developing allergies. And there's also cofactors, so things like exercise, alcohol, stress can affect histamine levels. And so they can make reactions more likely to happen. So there's a term in the allergy world called histamine buckets. And so if your histamine buckets get filled because you have exercised, then you're going to be more likely to have an allergic reaction to something that you didn't. There's also exercise-induced anaphylactics. So individuals that would not go anaphylactic, but again, if they exercise, they can actually have anaphylactic events due to that. So. And also keep in mind that individuals, they are over time, what can happen is known as allergic march. And so there can be changes in what they present. So they might present first with atopic dermatitis, but later on they're going to develop asthma or food allergies. And so again, there's just this constant kind of changing of what they're presenting with. So next we're going to look at a little bit at the mast cells and how they respond in different tissues. So here we have our mast cells that are going to be in the airway. And so here we got an allergen that's presented. Allergen goes and interacts with our mast cell. Mast cell degranulates. And the response to these inflammation mediators are going to be contracting of the smooth muscles, increase mucus secretions, and also increase blood vessel permeability. And so there's going to be increased fluid in the area of the tissue, and also decreasing of the airwaves. In chronic responses, we can also get eosinophils being involved in that process, and they are going to be degranulating also. This is presented in the textbook for asthma, but also keep in mind that if we have inhaled allergens, and so for some individuals like with peanut allergies, just the allergen being present in the air, they can respond to. There is an audio lecture on alpha-gal. Alpha-gal, if that's actually a sugar, not a protein. So normally allergens are proteins. So alpha-gal is interesting for a number of reasons. But that's also one that if the alpha-gal particles are in the air, individuals can have reactions from it too. So just keep that in mind. Now, when we look at the mast cells in the skin, we get the releasing of histamine and other immune mediators. And what this will cause is swelling in the area. And so that will present as hives or edema. So generally, the initial response will be more isolated, localized areas called hives, which we can see here on this individual. So next to R and H, you can see nice hives developing from that. And then that would become then general, where you'd get edema, swelling of the general area. Now, in the GI system, commonly with food allergies, you're going to get the mast cells interacting with the allergen and releasing of histamines, and that's going to cause the GI distress, vomiting, diarrhea. It can also lead to hives, and the allergen can also get into the bloodstream, and then we can have a systemic reaction. So again, keep in mind for food allergies, it's not just a GI presentation. They can also have skin presentation also, so they can get hives from it. And inhaled food allergens can also cause reaction. So it's not just from ingesting the food. So it's not a simple like, oh, well, just don't eat it. It's the most annoying thing to say to someone with a food allergy, just don't eat it. That's not always the simple answer. This is from a different textbook, but I think it's useful because one of the things you'll notice, this is for food allergy specific, so that textbook kind of focuses on food allergies as their model. And you'll notice that in the idea of an allergic march, you can go from having an acute IgE mediated response to something that then is also cell mediated. And if it becomes chronic, you can have it being cell mediated where you're having T cells involved. Okay, so just keep in mind that when we're talking about food allergies, this could include individuals with cell mediated immunity, which is a type 4 response, but they have the IgEs present, so they are still classified as a food allergy. Just to add some confusion. And again, keep in mind, when we're looking at different factors that can contribute to allergies, it's not necessarily just your parasitic worms, but there's other factors, and they can shift in either way. So environmental factors can either put you more at risk. So if you're in an area with high air pollution, low gut microbe diversity, depending upon your diet, that can actually interrupt your mucosal immunity in your gut, and that can allow allergens to then interact with your immune system, which then can lead to an immune response with genetic factors playing a role. Now, if you have a high fiber diet, really diverse gut microbes with beneficial microbes, and we see farmers tend to have a lower incidence of allergies. This keeps that barrier intact, so it keeps allergens, foods, and such out, so they're not able to actually interact with the immune system. And if they don't interact with the immune system, then you can't get activation of those B cells. And things like antibiotics will break down that barrier and lead to things like leaky gut. So with food allergies, one of the kind of more holistic treatment strategies looking at your gut and repairing that gut lining so you don't have leaky gut. A lot of individuals with allergies, especially with alpha-gal, they'll end up developing additional food allergies on top of that. And again, leaky gut's is believed to be a big factor in that. All right, so how do you get tested for allergies? Well, besides just clinically presenting with them, if you want confirmation that you actually have an allergy or you're unsure what the actual allergen is, there's skin tests or scratch tests that can be done. There's also patch tests that are done. And then there's also blood tests that can be done that looks at the IgE antibody specifically. I don't have on here, but there's also basophil assays that can be done. Those are more experimental. And the blood tests looking at the antibodies, IgEs that are present, that is becoming more accepted, but wasn't always. So we'll talk about each of these tests. So for the scratch test, what happens is a small amount of the allergen is put on a needle, and then the needle is kind of scratched on your arm or pricked. So sometimes this is called a prick test, scratch test, skin test. And then the individual is monitored for 30 minutes. And after 30 minutes, they look to see whether a hive has developed. Okay. So controls are used. So negative control and your positive control is the histamine. And then you can see on this individual is allergic to a number of things that are presented. Now, one of the downsides to this is you're exposing the individual to allergens, and you're looking at a skin response where these allergens aren't always causing an issue on the skin, right? So for some allergens, right, we're inhaling that. Well, our skin is not our respiratory system. Some of these allergens, not so much the ones presented here, but you would be eating those, right? And so this doesn't represent what's going on in the gut. This is the skin. So for some individuals, they are not going to respond on the skin test the same way they actually clinically present or what their blood test would tell. Also, some responses are delayed. So if you're only monitoring the individual for 30 minutes and you have a biphasal response and you say go on your way, they could be having a second response not in the doctor's office. And generally what's going to happen is the individual would be recommended to take antihistamines after the skin test to alleviate some of the discomfort and pain they are experiencing from positive reactions, and that can help with any second response. But for some individuals, again, and I'm biased because I'm thinking of alpha-gal, for alpha-gal, these individuals won't respond in the first 30 minutes. So this is more indicative of a protein response. For alpha-gal, their response is a delayed response, which is very atypical of an allergic reaction, but that's what they are. And they can respond anywhere from hours to even 24 hours after exposure. And again, they would not be staying most likely in the doctor's office for 24 hours to be monitored for hives or any kind of reactions from it. So not always the best test, but again, it's kind of the standard test that they'll do. But just because something is the standard doesn't mean that's what it should stay that way. Patch test, this is commonly used for chemical allergies. What's going to happen is the allergens put on this kind of patch or kind of tape, and then that is put on the back. A number of different chemicals can be screened. The patch is left on for about 48 hours and then it's removed. And then the individual comes back 48 hours after that to be evaluated to see if there's any kind of hive response. So keep in mind, a lot of times with chemical, these might be delayed type reactions. So this is kind of a nice way to test. However, it means it's 3 days that the patient has to come into the doctor's office. So day 1, they get the patch applied, and then day 3, they come back for removal, and then day 5, they come back for reading. In some cases, an additional readings have to be done 7 to 21 days after application. So you can imagine for some individuals, this is extremely time consuming. This is also relatively expensive to do because you have at least 3 doctor's visits that you are being charged for. And plus, they don't usually just do one chemical, they're doing a number of chemicals present. You're also, like the skin test, you are exposing individuals to allergens. Not everyone reacts typically. And you have to, for both the skin and the patch, individuals are told not to use any antihistamines or medications for their allergies during this time. So for someone who it's incompatible with life to not have their antihistamines, either of these tests are not probably best for them. So what is sometimes less common as the default, but is becoming more widely accepted, is taking blood and looking at serum levels of different IgEs and what allergens they recognize. So this can be done in the physician's office, but there is actually a home test that can do that. So you can actually go into your CVS, your Target, whatever, and there are companies that offer, food allergy test, environmental allergy test, and you provide them with a blood sample, and then they isolate the antibodies, and then they give you a report back of what you are allergic to, so that you can then make decisions. Obviously, this is always best to work with your PCP or your allergen to make decisions upon your treatment and such. So there's a number of different drugs that can reduce the symptoms of allergic reaction. So generally antihistamines are used. So second generation antihistamines tend not to have effects on central nervous systems. So first generations like Benadryl will make you sleepy and drowsy. That's because you have histamine receptors in your central nervous system. And so when you take antihistamines, it blocks them and makes you sleepy. So things like Claritin, Zyrtec, and Allegra bind H1 receptors, but they very poorly cross into the central nervous system, so you don't get the drowsiness effect on that. Leukotrienes and antagonists can also be used. Steroids can be used to, and that helps to reduce the inflammation that's associated with a number of allergic reactions. So things like Flonase would include a corticosteroid. And then epinephrine is used. So epinephrine is going to prevent the further degranulation of mast cells. And they do this by binding the G protein coupled receptors, so you don't get the cyclic AMP signaling, so you don't get the cell signaling events. And then there's therapeutic anti-IgE antibodies that are also used. There are some other treatment strategies to desensitize allergic responses. So things like allergy shots, sublingual application, and oral immune therapy, so you're actually fed parts of the allergen. The oral immune therapy is found to have the best results because allergy shots, you're introducing the allergen into the bloodstream, and so that has a higher potential for anaphylactic reaction. Again, this allergy shot should be done in the doctor's office for that reason, and individuals should be monitored after receiving the shot to make sure that they're not going to go into anaphylactic. So this figure just shows how the traditional allergic response works versus when you're desensitized. With the desensitization, there's going to be presentation of the antigen, but you're going to get involvement of T regulatory cells that are going to suppress further activation, so you're not going to end up generating that isotype switching by the B cell to produce IgEs. You can produce IgGs, but you're not going to end up getting the production that would lead to an allergic response. All right, and so the remaining slides for this PowerPoint are on alpha-gal syndrome. So there is a separate audio lecture for alpha-gal syndrome, so I recommend going and watching that. Alpha-gal syndrome is our model allergic reaction, even though it is not a traditional allergic reaction. It's actually really nice because you can kind of compare and contrast a traditional allergic reaction type 1 response versus how alpha-gal syndrome individuals present. And some of that has to do with it being a carbohydrate that the immune system is targeting versus a protein. It's also about how the alpha-gal gets into your body because it's a carbohydrate versus a protein. So really interesting syndrome. It's called a syndrome because there's a number of presentations with it, and there's a number of complications that arise from having this allergy to alpha-gal. Humans don't make alpha-gal, so we don't inherently see it. But for individuals with alpha-gal syndrome, alpha-gal has been introduced into their bloodstream, so they develop an allergic reaction. They develop IgE antibodies against it, and then they develop allergic reaction, not just to food items with alpha-gal in it, but it can be everything from personal products to medication, and also alpha-gal just in their environment. So it's not even that if they are making sure alpha-gal is not present, if they are interacting with other human beings, they can respond to the alpha-gal that's on them. So again, really interesting case. So please go listen to that audio lecture. Please ask questions about alpha-gal syndrome. I do have a extra insight on that as someone with alpha-gal syndrome. So, all right, thank you very much. Have a good day.